And so if you get to that sort of fundamental level, then I think that's where we can work together in the best way.
Good morning, everyone, and welcome to our second inquiry session as part of Curia's NHS Innovation and Life Sciences Commission. I'm very pleased to welcome all our commissioners here today who will be putting some of the questions to the panel, and also our panel members who will be introducing themselves shortly. The aim of this commission was to look broadly at areas where innovation and where the health service and the wider public sector influencing the health service are having both successes and difficulties. And we're looking at a more enabling approach here rather than the usual critique of what is going wrong in the services. And heaven help us, there's enough of that at the moment after the Parliamentary Committee's report yesterday on workforce, etc. None of these issues will go away, but it's gratifying to know when things are actually working and going well. Since the beginning of July this year, of course, we have seen the implementation of the policy and the actuality now of integrated care systems and integrated care boards being set up. And therefore, it's very opportune that this second inquiry focuses on integration. I think many of us have been working in the health service and trying to integrate health and social care, or indeed just all the different aspects of healthcare into one solid and accessible form, and it strikes me that has taken a lot longer than many of us envisaged it over 20 years ago. But we are where we are now, and we have new leadership in the ICSs and a new mandate for them. And it's important that we find out today, I think, what that mandate will look like, how it will work in practice, and what the challenges are to the system. The format of today, which will be recorded and will be available online at a subsequent time, is that we will invite each of our panelists to give a 2-minute introduction to introduce themselves and their expertise in this area, and perhaps some initial comments. And then I'll ask my colleagues to pose questions. And for the first hour, I will look after those questions and try and organise the debate, including what you will put in the chat. And I encourage you to put both questions and comments in the chat so that I can bring those to the attention of the commissioners who are asking the questions, and of course the panelists. At the end of an hour, roughly an hour, my colleague Lord James O'Shaughnessy will take over and run the second half of this webinar. And as he will probably comment at the time, it's important that we think of this as a continuum and not just separate sections of the problem. We're trying to get as broad a pitch as we can, but there will be new speakers in the second half, and James will introduce those to you. So I'm going to ask my fellow commissioners now to introduce themselves. I should do myself first. My name is Mike Buick. I'm the former National Deputy Medical Director, NHS England. I'm now an independent health consultant, and my chair is in digital health at the University of Central Lancashire. So James, do you want to introduce yourself first?
Thanks, Mike. Morning, everybody. James O'Shaughnessy. I am Senior Partner and Co-Founder at New Market Strategy. It's a market access consultancy and a former Minister for Innovation and Life Sciences in the Department of Health and Social Care. I'll hand over to Keith.
Good morning, everybody. I'm Keith Ridge, and until February early this year, I was Chief Pharmaceutical Officer for England, having done that for 16 or so years, and prior to that, Chief Pharmacist at University Hospitals Birmingham, Glasgow, and prior to that, a session at the department where I helped set up NICE and various things like that.
Seamlessly, should we go to Gillian at NICE?
Hello, I'm Gillian Leng. I was at NICE for over 20 years. I left a few months ago, so I spent many years working with the life sciences industry and with the NHS to facilitate change, evidence-based change, of course.
And finally, Richard.
Morning, everyone. I'm Richard Stubbs. I'm Chief Executive of the Yorkshire and Humber Academic Health Science Network and also the Vice Chair of the National HSN Network.
Thanks very much. Just to mention that this is the second of our inquiries. The first one we held a few weeks ago on data, and we're privileged at that time to have Ben Goldacre with us, and the Goldacre review had just come out. So it's interesting how things seem to be evolving in the areas that we've chosen. They seem to have become very pertinent topics of both discussion, debate, and particularly for policymakers, I guess, as we go along. The future ones are going to be around clinical research and on scaling, but this one, as I say, is on integration. And I'm going to introduce my panel today, if I may. Clare Gerada I'll introduce first, and then we'll go on to Hamish Dibley, Neil Modha, and then Stephanie Harvey. So Clare, nice to see you, and perhaps you could give us your 2-minute introduction before we move on to questions.
Yeah, thank you very much. I'm Clare Gerada, a GP, and currently president of the Royal College of GPs, but my views are my own, as they say. So thank you for your introduction, Mike. I think that what we need to be asking here is not why. I mean, it's not what, but why. I mean, because we've been talking about integration. Certainly, I've been a GP or doctor for 40 years, and I was born into a discussion around integration. And yet, with very few examples, and there are some good examples, we don't have integration. You said don't focus on the problems, but I would like to say that if we're going to focus on the solutions, we have to ask ourselves why we're still fixated on a model of service delivery that was developed after the last plague. So for more than 500 years, we've had a system where we have a division between hospitals and the community, where we send those rather antiquated things called letters, where we have separation between staff, we have resources that are not predicated on shared working, and we have built in to the entire system the inability to integrate unless people are very brave, and I hope ICSs will be, and redesign care pathways. Now, what I bring to this expertise is I've actually run 3 integrated services. So I have run 3 services that I would call true integration. And by true integration, I mean shared care between different parts of the system, whether that's primary and secondary, primary and third sector, or whatever, where you have the patient is shared between you. We have a shared electronic record, ideally a shared budget, and where we have communication that goes beyond the simple exchange of letters. So if we're going to get beyond this, we've got to start saying, how can we empower ICSs, not just to create very fancy documents, which we've had, and you know this, Mike, I mean, there's so many reports that come out of the sector around what integration is, but actually get on and move it and redesign care pathways into a modern era where we know we have to go. And just finally, before I shut up, not so long ago, I had to do 3,000 digital consultations, mainly because we were so far behind. And I acted as a computer. I did a first cut triage, if you like. And over that weekend, I learned a lot about patients, and I learned a lot about the wastage we have in the system. But actually, on the whole, there are patients who know what they need, so they might already have a chronic disease and they need a referral or need to be seen by a specialist, or they have something like a breast lump or testicular lump, they know. There are patients who are uncertain, where we have to maybe do some diagnostics, and there are patients that we know on the information that they give us what and where they need to go. And if we create a system that uses a front-end digital triage, possibly with AI supporting it, and actually stop this way of, I know somebody needs to be seen, I then have to write a letter, the letter takes 5 weeks to be responded, they then see exactly the same history, they come back, and I'm we've gone full circle. So I think we need to move on from describing the problem and actually describe why we're not moving on at all.
Thank you very much, Clare. I totally agree with your view there. But just to clear up, we're not ignoring the focus on problems. It's looking to solutions and finding best practice and case reports. And you've just given us some examples of that, but the frustrations that go with that. Can I move on to Hamish, please? Thanks.
Morning, Michael. Morning, colleagues. My name's Hamish Dibley, Consulting Director of BearingPoint. I have a lot of experience of working in healthcare, both working in the NHS and affiliated services. So I've held senior management positions in local government and the NHS prior to going into management consultancy. I echo a lot of what Clare has said. We have been spending an eternity talking about the need to integrate care, but actually without understanding the what and the why, or the where and the how. I passionately believe that part of that problem is because we don't actually come at the problem from the right perspective. We need to humanise healthcare. We need to think about what matters to people who need health and care services at different parts of their life cycle, life journey, we also need to recognise that, for me, care integration is often seen as a panacea, and it should not be seen as a panacea. We need to understand who needs care integration and then a preparedness to design for it. That will then have a major ramification in understanding population health, for example. When you actually look at the view of healthcare from the perspective generally of the patient, what you find in every healthcare economy is what I call the vital few concept, which is 5% of every geographical healthcare entity, which will be behind 20 to 30% of the work activity in totality and 30 to 40% of the costs. It is those individuals, those people, those networks, those loved ones who need integrated models of care. And I say that in plurality. We are talking the language of models of care based around cohorts of patients, not trying to design for standard pathways. But I'm happy to expand on that during the course of this conversation.
Thanks very much, Hamish. You make 2 points. I think the ICS is responsible for that rollout of a population health model, but that sort of nuanced version of it, which is around either the individual patient and their needs or their community of patients. And I think that's well worth stating up front at the beginning. Thanks very much. And Neil, could we move on to yourself?
Hello, thanks, Mike. My name is Neil Modha. I'm a GP from Thistlemore Medical Centre in Peterborough, and I've been a GP for 14 years, not 40. And in that time, I've grown my practice from 7,000 patients to 30,000 patients. We look after a very atypical population. 80% of them don't speak English, and they're amongst the most deprived in our ICS. And I guess through that, I really do believe in a broad, wide-ranging team to support our patient population. So lots of additional services that are now in my GP practice really add a lot of value to my patients, from drugs and alcohol to preventative services. I'm a big fan of the NHS personalisation agenda, which I think our last speaker was talking about. How do we actually do things at scale, yet how do we meet individuals' needs? Because that's truly what any service should try and do. I am a previous CCG accountable officer, management focused, and now I'm the clinical director for a primary care network. I chair a GP federation that supports 300,000 people around Greater Peterborough, and I co-chair a place-based board. So I guess the perspectives I bring are kind of different system levels. And one of my kind of current missions is the primary secondary care interface. I recently worked on the Clare Fuller stocktake, leading the area of population health management and data. So I'm happy to contribute to this session. Thank you.
Thank you very much, Neil, and thanks for highlighting Clare's work. And we'll be speaking to Clare in the second part of this webinar today. And finally, Stephanie Harvey, if I could ask you to introduce yourself.
Hi, really nice to meet everybody. I'm Stephanie Harvey. I work for Lilly, who are a pharmaceutical company, for those that don't know. I'm the NHS Collaborations Manager for the UK. So as the title would suggest, I manage all of our collaborative working projects, joint working projects, donations of service to the NHS, and sponsorship of NHS initiatives which are aimed to improve patient care. The common theme through all of that work is that all of these projects are outcome based. They're all also supposed to be innovative and proof of concept projects, which don't just impact the NHS at a local level once we've kind of proven the concept. The aim is always to scale those projects throughout the NHS, and that's where the difficulty comes in. I think I have a lot of experience and success in delivering projects at a local level with tangible outcomes in service improvement in patient outcomes, but actually when it comes to scale, and the barrier to that is often integration. So very interested in the views of the panel and commissioners today, as well as managing the portfolio of our projects and my previous experience as an improvement consultant. So I try to actually work within the project as much as possible still. And I still find that most of the innovation is brought to the table by clinical teams. So I'm extremely interested in the views of colleagues here today on how practical solutions can not only be implemented at ground level and my experience from ground level, but can be scaled within the new NHS ICS structure across those old boundaries, primary care, secondary care, social care, when we've actually struggled so much in the past with actually scaling within the boundaries of healthcare. So I think we have an opportunity when these organisations are in this fledgling state to have hopefully frameworks and capacity that wasn't built in before to really allow these type of partnerships to flourish. and really appreciate you having Pharma at the table today and having a seat here to have these discussions.
Thank you very much. This inquiry and most all 4 inquiries, this has no political base and no restrictions on who we can talk to. And I think it is important that we get industry's view of this, especially as you're working with ICSs and previous guys, CCGs, etc., in looking at how that best practice can be adopted and put up at scale. We're going to move on to our inquiry section now, and I'll introduce Keith in a second to ask the first question. But given that much of the work to deliver integrated services will happen at the place level, operationally, elements of the NHS and flexible deployment of healthcare staff must be examined within the objectives of integration. In other words, how are we marrying together a centralised system with a place-based system? So, Keith, do you want to fire away with your first question?
Okay, thanks, Mike. And I thought I might direct this at Neil, just to kick this off, if that's okay, Neil. But given your description and experience, which we know about in terms of all levels of the system, that seems appropriate. So the first question is, how will new health systems have, and indeed use, the freedom and capacity to rethink how staff are deployed and utilised across a system to achieve better health outcomes? And within that, Neil, if you could just sort of reflect on what employment barriers exist and how they can be overcome.
Yeah, thank you, Keith. So I think it's really important, isn't it? I mean, staff is the answer to the NHS problems, isn't it? So having a workforce that is fit for purpose, that is kind of not tribal. So although we might have lanyards around the organisations that kind of host us or employ us, then I guess in the future, the idea is how do we as a system work together for the people that use it? And certainly if I look to our local system in terms of like, employment passports and kind of making sure that things like mandatory training, the relevant kind of employment checks all kind of port over is active work that we're doing. I guess the challenge there, though, is that once we start moving staff around are we just kind of creating pressures elsewhere in the system? And so what we are actively trying to do is to kind of bring more people into the NHS. So kind of, if I use my GP surgeries as an example, we employ lots of people who've worked in factories and fields and farms, give them the skills and the experience to work in healthcare. And many of them have gone on to become kind of obviously healthcare assistants, nurses, doctors, physios, many working in the local health systems. We must have trained about 400 or 500 healthcare assistants. If I look at the federation scale, which is a network of general practitioners, we've created a kind of a network of, for example, healthcare assistants working on mental health to actually support people with severe enduring mental health illnesses. And what wouldn't have happened, I guess, about even 5 years ago in general practice is, I guess we wouldn't have trusted each other, that we could have a workforce that's working on behalf of Greater Peterborough. So I think some of the key components have been kind of trusting each other, having faith in the training, have faith in the support, and having faith in adding value to patients. If I look at the place-based agenda, we have recently set up kind of like a GP liaison service, or a service between the primary and secondary care interface, which is kind of part funded by the hospital and part funded by primary care. And the hope is that actually the more we work together, the more we share staff, the more the staff are working for a common purpose. I think those are the ingredients that I see that will make us closer together. I think it's really hard to integrate, an organisation with a £500 million turnover and a £1.5 million turnover. They're two completely different organisations with different structures. But I think when you get down to it, and so if you get to that sort of fundamental level, then I think that's where we can work together in the best way.
Mike, you happy if I just...
Yeah, sorry, I was expecting you to come back.
So, it's very helpful. I particularly like this sort of, everybody working to a common purpose and sort of everything flows underneath that in many ways, isn't it? So, but the practical side of, let's just call primary care, and you'll know what I mean, as contractors are, let's call it private sector. That's not the right term, but you know what I mean. As opposed to
we're not private sector.
As opposed to the NHS. No, I understand what you're saying, but in terms of being employed, then as employers, they are different. Primary care contractors are different to hospitals. Of course they are. So Neil, I'm just wondering how you've sort of addressed some of that. You've mentioned passports, but are there other things which have
I mean, I fundamentally say that I probably like Claire's chipping in. I don't feel very different to the hospital sector. I've got a budget, like the hospital's got a budget. A certain amount of that will be my income, a very small amount of that. Normally a quite fixed amount, because not many of us are motivated actually purely by finances. The rest of it then goes on to service provision. And I guess, the mood of the NHS, hasn't it? There has been a huge investment into primary care, not directly into our kind of core budgets, but into the field of ARRS, so additional roles within primary care. And so certainly since the PCN agenda and the ARRS, my PCN has got an additional 30 to 40 staff, and some of that staff are people that wouldn't have previously been in general practice. So, for example, it includes physiotherapists from the hospital. So 2 physiotherapists come each week, employed by the hospital, but come into my GP centre. And so, actually, I think that cognitive dissonance almost. I think the further we go down the path, the less that us as leaders of general practice feel like that. We don't feel like we're in a private sector. We feel very much public sector. And I guess in that journey, that my journey of integration for me is about having lots of different, as well as having an MDT team within my practice, physios, pharmacists, and that kind of stuff, having people from different sectors, drug and alcohol, from the council, healthy living and lifestyle, from the voluntary sector, we've subcontracted some contractors to bring them in to both do work in the practice and outside of the practice in terms of health and well-being and things like that. So I think probably for me, the answer is, again, people and staff. And I think as we go further on this kind of PCN agenda, I do think there are some helpful parts of it, such as it encourages primary care organisations to think beyond their walls and to think about how other organisations can do it. At the start of the primary care network agenda, it didn't happen because we had 1 or 2 staff, and so we wanted those staff for ourselves because obviously it was sold in terms of stabilising general practice. But the longer we go on in this agenda, the more we bring in other people to help serve the needs of our population.
Do you think that applies to all the primary care contractors?
I think the wonderful thing about general practice is it is very varied and wide, and so I think it's really hard to make it, but I think people that I speak to, do not consider themselves private contractors.
No. Okay, I withdraw the private sector comment, just for clarity. Yeah. But there are 4 contractor groups in primary care. So do you think that what you've said applies to them as well?
I think so. So having had the pleasure of leading one of Claire Fuller's work streams in population health and data, I mean, when we kind of got around the table with dentists, with optometrists, with pharmacists, the common kind of vibe, I guess, was how do we work together to make things better for people? And I think in this kind of deluge of activity that we're all facing, I think it makes it a lot easier for us in the general practice world to go, well, actually, I need the help of a pharmacist. I need the help of an optician. Why can't opticians be more empowered to do more things for patients, rather than involving general practice? So I think in a way, this kind of perfect storm of pressures on the NHS will hopefully create the perfect kind of channel to ensure that kind of primary care in its wider sense does work together, because general practice alone cannot solve the problems that face community care.
Neil, thank you very much, and thanks for being our first respondent. Claire, I'm going to bring you in briefly, and we're not going to touch on the private contract. I think we've sorted that out in the chat. But in terms of what Neil has just said there and how we go forward, is that your experience as well?
Yeah, I mean, I think what Keith asked was what needs to change. I absolutely agree with Neil, everything he said. I mean, for primary care, we need to change the legislation, in particular the performance lists legislation. We need to change the contractual arrangement. So, for example, the simplest thing would be if I wanted to have an elderly care physician working in my practice, number one, they would still have to have their RO, and their RO would be based in a hospital. So I cannot, unless I have my own RO, directly employ as
You
secondary
mean
care
responsible
practitioner.
officer, for those who might not know that?
Yeah, responsible officer.
Yeah.
And even if I could do it, they would not count against the number I have to see and treat with respect to the contract that we hold with NHS England. So there are some real concrete methodological problems that need to be sorted. There's also, and I think we've learned from COVID, and I think Neil touched on it, the working to the top of our license. I think there was certainly before COVID, but COVID exacerbated the solution, which is, and I call them omnicompetent clinicians. And for example, paramedics and physician associates tend to come from the same stem. We've got a multiplicity of providers now working in general practice, so many that actually not even I, working with them all, can distinguish between where one level of competence begins and another one ends. So I think we need to be looking at omnicompetent practitioners, and there may be ones with special interest areas. We certainly, and this is for the longer term, if we're going to bring about any meaningful change, we have to make sure that every single, I say doctor because I know doctors best, every single doctor, irrespective of their end point, works in primary and community care, just like every GP has worked in hospitals, and not just at FY level. I mean, foundation years. I mean, at a time when they are able to take responsibility, manage risk and uncertainty. So, for example, maybe ST3, ST4 onwards. Because the patients we know that we're seeing today are not the sort of patients we saw 50, 60 years ago. They're patients with complexity, multiple morbidity, and every single clinician, irrespective of their specialty, needs to be able to manage those in their totality without having to have the handoff. So I think those are just sort of some of the top level things that I've been thinking about, let alone reforming who can work in primary care, so we can have more or less any non-doctor specialty working in general practice. Let's say it's general practice, primary care, anything from, as we know from Keith and the fabulous work pharmacists do, to physician associates, to physiotherapists, to paramedic, but we cannot have a non-GP doctor working alongside us, except with really complex arrangements. We certainly can't have non-GP, people who've trained as GPs that maybe have been unable to pass the MRCGP. So there isn't an equivalent, for example, of a staff and associate grade in general practice. And then finally, we have the problems of, and this came up in Jeremy Hunt's report yesterday, the madness of bringing doctors into our system, doctors and nurses, the complexity of going through the processes. And I don't just mean the obvious processes of checking that they're fit for purpose, checking that, you know, from their host country, they've done the necessary training, but beyond that, the inability to put in very experienced people and plug them into the NHS without them having to almost retrain. So those are some practical issues that I think if we're going to sort this system out, we have to start at a system level, at a leadership level, we need to start addressing.
Okay, thank you very much, Claire. And you sort of preempted part of the second question. So Gillian, could you introduce that question?
Yes, thank you. And indeed, the question was going to be directed at you, Claire, in the first instance. So you might have answered some of it. But on the assumption we all agree that we need the right people with the right skills and training to deliver collaborative person-centred care, this is a how question. So how do we coordinate and deliver that workforce planning and education? How do we deliver it both at a local system level, and how does that local system then link to regional and national planning and policy? So,
and Gillian, I think that is the $64 million question, and I have been around long enough to be looking at workforce planning. I mean, when I qualified, the big issue was still TB and TB hospitals, and we had an massive excess of TB doctors because we had trained them in order to deal with all of the problems. Fortunately, they managed to retrain and deal with what was then the HIV pandemic. My feeling is it has to be at local level. I think we need to move responsibility for training out of, and please forgive me if I'm treading on people's toes, and these are my views, not those of the colleges, but for example, out of HEE, whatever HEE morphs into, and much more into the local area, whether that's the ICS or whatever the local geographical footprint, who are much, much, much better suited to determine their workforce planning and also their training a training of the staff that are going to work in the NHS going forward. We also need to be thinking imaginatively. I went recently to the College of Paramedics, who was celebrating, I think it's their 20th or 25th anniversary. And I was struck by a comment that was made by their president. And it really struck me, the importance of paramedics, not to dismiss the importance of anybody else, but paramedics are the only group that work with any patients anywhere. And yet, in order to bring them into the system and out of the ambulances into primary care, it's been a long journey. And yet, wherever we find paramedics, and I would also say pharmacists and physician associates, they have been a wonderful success. And yet, I don't hear at sort of senior level about these groups. I mean, I do at pharmacists, but they seem, I mean, the physician associates, got a bad press not so long ago. They're fabulous. So I think it has to be done at local level. I think we need to remove it from universities and workforce planning away from universities. And finally, we need to read Jeremy Hunt's report because I think he's got some good ideas. The Netherlands, by the way, have a 20-year workforce planning agenda, 20 years. And they bring together the major stakeholders. They look at it every year with population health needs, but they look at it in the long term. And I think we tend to, well, we don't have workforce planning as far as I'm concerned.
Thanks for that. Gillian, do you want to follow that up?
Yeah, just briefly. So in terms, Clare, of things moving to be more locally coordinated and driven, which makes absolute sense. How does that then link across the whole of the country? Because if it doesn't, I guess we might end up with different models that are hard to coordinate and hard for people to then transfer across into different models.
And that's again very important, because what we don't want to get into that you trained in one area and not fit for person, Lincolnshire to Cambridgeshire. I think Neil would be very annoyed if he couldn't steal the Lincolnshire staff to work in his Cambridgeshire practice. I mean, clearly we've got to have an overarching body that looks after it, but I would say the overarching body has to be more aligned to NHS England, which I think it is. I'm not, the structure of the NHS is changing so rapidly, I can't even keep up with it. It has to be more aligned with NHS England than, for example, the educational bodies, which train, which obviously have to do the training, but I think the planning has to be done at a much more health-based. But at local level, I think once you've developed your competencies, I'm not saying that local areas develop their own competency frameworks. I think those have to be done nationally, but I am saying that local levels must be able to determine. So Neil, for example, was talking about the rural fenlands, where the needs, I imagine, and the massive Polish population may well be very different from my practice area, our ICS area, which has a very dense population, dense in terms of population, numbers. And so I think we have to look at local level being able to determine. And finally, I think we always don't start at models. We start at clearly what we're trying to achieve, and then the model works naturally up from that.
Thank you. That's really helpful, Mike. Thanks,
Claire, and thanks, Julian. Just to say, I think the workforce planning has been an oxymoron for as long as I've been involved with it, and it appears we're not very good at that long-term vision. And just looking through the chat, some of the earlier comments were, should we be pushing for a much longer-term settlement so that we know financially what we'll be dealing with? And I guess that's something all chancellors and health secretaries would love to do, but elections do tend to go in the way, as do political downfalls. So I suspect it's a holy grail we'll never really achieve, but a 3-year programme might be more helpful than in one. So maybe, James, we can talk about that another time. But Des Breen, who's speaking in the second part, has been commenting about competency-based and skill-based rather than professional-based. Now, I think, actually, Claire, I suspect would resonate with your approach and trying to use people in the context of their skills rather than in the context of their workplace. We're going to go on to topic 2 now, and I'm going to ask Richard to ask the first question now, if that's okay, Richard. And then this is really about, we've had an NHS long-term plan in the making, and unfortunately we did have a pandemic in the way. But there is a relative lack of a national strategy, and I think, Claire, you've mentioned that just there, haven't you, in terms of NHSE setting the agenda, and no doubt Des will talk about that a little bit more in the second half of this. But we need to establish what true integration looks like and how it can be achieved. And I guess that's the other $64 million question, is the description of what we do and how we do it. So Richard, could you just introduce the next question and perhaps indicate who you're going to ask it to?
Yeah, thanks, Mike. And I'll do the second point first. So I think particularly Hamish and Stephanie, looking to you for this one. But my question is really about what is required to achieve integration across all stakeholders. And when we talk about all stakeholders, we're really meaning the health and the life sciences ecosystem. So I suppose consider this a very broad integration vision, so including obviously, but also beyond primary, secondary care and the social care sector. So Hamish, if I can start with you, your sense of what would be required to achieve real integration across health and life sciences as an ecosystem.
Thank you, Richard. And I should at this point add that I've been part and parcel over the years of doing this as part of the alphabet soup, as I call it. Back in my day, it was about accountable care systems before we talked about the world of STPs, and now we're talking about the world of ICBs and ICSs and ICPs. So to answer the question, I think we need to really break it down into its component parts. So for me, it starts with kind of the design of the system and what we want it to be in terms of a what and a how. So we talk a lot about health and social care, but that's kind of more or less silo thinking. What we really need is a preventative well-being system that is purpose-driven around identification of the needs of the populations, not just population, because what primary care and Clare will experience and Neil will be different necessarily from what the challenges are in adult social care, community mental health, the ambulance service. But it's moving away from that task-driven function design of work. It needs to be locality focused, and we need to be thinking about having relationships and continuity of care at the heart of any work design, as opposed to what happens at the moment, which is very much task orientated around activities where we allocate resource, we allocate time, we allocate functions, and we'll refer work on once we've done our bit. How that then impacts on things like commissioning is pretty fundamental. So again, we need to move the dial away from service provision to more of a focus around people and understanding different cohorts and their requirements, and then moving towards what I would call a responsibility system. So if I can be as bold to utter a few thoughts on Gillian's question just previously, what I think we need is a responsibility system that enshrines the principles and practices around continuity of care around whole people and their experience and their outcomes. We also need to free up healthcare professionals to lead and manage more appropriate system-wide interventions for people who we may label different things in different parts of the system, from service users, clients, adults, patients, high-intensity users, when they need them and why they need them. And then we also need to think about workforce along those lines. So we need not an activity-based workforce where, again, people will do their bit and then hand over. We need to build continuity systems that's based on authority and responsibility. It's the Frederick Hertzberg line, isn't it? If you want people to do a good job, design a good job to do that's an enriching job, that it sustains and embellishes. There's something also for me around performance measurement, which I don't think we've given enough credence to. Too many measures. We're working right now in a system where what one part of the system thinks is good performance is the polar opposite of another. So what does that mean moving forward? For me, that means purpose-driven measures that are derived against the user. It means a focus on effectiveness, not activity efficiency. And it means an understanding holistically over time of the end-to-end effectiveness of what we do and how well we do it. And things like that could be looking at the capability of the service, the healthcare consumption, handovers, the level of stability that we're achieving. And overarching all of that is obviously budgets and finances. And my plea would be, let's focus on the reconciliation of the money at the back end, not the front end. We too many times have unseemly conversations that last too long and are too counterproductive around who should be paying for what and what should be done. Costs are a lagging indicator. So what we should be driving for is one system, one budget, with empowering people with responsibility and authority to spend the money as they see fit, and have teams of people designed around cohorts of patients, and that it's based on ownership and continuity, so they can actually understand as opposed to assess the problems. And I think if we can strive for that, and I'd come back to, I think, Stephanie's point that she made earlier, how do you achieve this is always the thing where we fall down over the decades. Well, for me, it's like how you eat your elephant. It's one bite at a time. It's thinking about proof of concepts, not trying to tackle an entirety of a healthcare system overnight.
Yeah, thanks, Hamish. And before I come on to Stephanie for her views, very interested in what you had to say there, particularly around preventative wellbeing systems. I often talk in my places about rooms that aren't labelled health, where health investment decisions are made, and how do we have a more cohesive influence on those rooms. So mayoral combined authorities, for me, are a good example. Hamish, if this is a football pitch, in your vision of integration, are there any players who currently aren't on the pitch who need to be, but maybe are sat on our subs bench?
That's a good analogy, Richard. The answer is yes. When we talk about health integration or health and care integration, I think it's too narrow. And what we need to do is kind of reduce those artificial Berlin walls. And that happens at a medical perspective, but it also happens at a managerial perspective. So there is a whole panoply of issues that need to be addressed that are beyond health and care. So some of the biggest problems you experience in emergency urgent care services are actually, how do we build and design services that are preventative in focus, that look at those non-medical needs as much as those medical needs. And they could be environmental, they will be housing related, they will be social, psychological. That requires a holistic understanding of, in other words, what's the nominal value of the problem we need to solve for the patients that are presenting, and what that needs to look like in terms of the agencies, not just a particular department within local government, but also greater use of the voluntary sector and their capabilities, and actually build them into the tent as opposed to keeping them separate. Too much of the conversation is only ever about adult social care, when actually, when you study the work and you understand the needs, as we all do, of these individuals, you realise that actually some of those problems cannot be resolved through any MDT meeting of a health and social care professional, because the problem is more wide-ranging than that. And so therefore, our response needs to be in keeping with the need of the problem.
Thank you, Hamish. Great. Stephanie, interested in your vision for integration, please.
Yeah, well, I suppose integration of life sciences is a rather large question in terms of, are we looking at R&D? Are we looking at the introduction of new medicines into the system? Are we looking at, collaboration? I suppose for the purposes of today, with this being more from the ground level, it would be the latter two. So new medicines into the system and collaboration, which I think have some similarities in the challenges and the opportunities. With there being a lack of a national strategy, or as well in terms of national guidance at ICS level, there seems to be a gap in terms of where partnerships or any collaboration with life sciences should sit. And is there one common board that could actually, appraise this type of work? Because where I see there being a real gap is that there are innovation accelerator type initiatives where you do something, it works, you take it to them. That has its limitations, will you actually get on that accelerator? And then actually, what is the impact of them? I've had pieces of work before that have ended up on, the NHSX playbooks. It hasn't helped to scale them at all. They haven't been adopted by other NHS organisations. You've then got bodies like the ABPI or the HSNs who may put out pieces of work to industry and in your pitch for the best partner. But where I think there's a real gap, or in the most common type of projects, really, so in the most common type of innovation, and which is that clinical teams spot issues before they arise and try to put innovative solutions into play to solve those. And we then have the proof of concept projects that Hamish has discussed. And these can be, I think we've got a real opportunity with new medicines, because, new medicines can be great for patients, but they can cause real issues on kind of the system if they have resource demands that weren't previously there. And these, proof of concept pilots that improve service delivery. What we really need is somewhere that if we have an idea, we have somewhere to take that idea. Obviously, it will be linked to a sort of ICS priorities, but where do you actually then take that idea to say, okay, this is in line with what you want to do. We have this, this blueprint for this proof of concept innovation. If we make this work, you take it on and scale it, because we don't currently have that. So what tends to end up happening is, we either have to ask the clinical team in advance to get that stakeholder buy-in at a higher level, and that's just not their job. They're already overworked. I'm amazed at the people that I work with in projects. They are the most hardworking people I've ever worked with. They're absolutely, doing more than they should be doing in terms of their NHS role, and then they take on this additional role to actually try and better support the patients that they serve and the services that they work in. So to ask them to then go and do kind of a high level stakeholder engagement piece is just not something that's ever going to work. So what tends to happen from a life sciences industry is that we try to be the change managers within the NHS. So we take on that proof of concept pilot success, and we try to embed that in other NHS industries. And it really needs to be the NHS that actually owns that change management piece. But without that central board to actually feed these ideas in and get buy-in before they happen, and then say, okay, we've proven that this concept works, you now run with it. I think without actually having that, that's where we've got a real gap, or potentially a real opportunity.
Thank you, Stephanie. That's really good, and actually a nice segue into what will be one of our future sessions on scale. I think some of the challenges you've outlined there. We do often, I think, default to a "if we build it, they will come" type of model in the NHS. It does not work like that. I'm sure we'll get into that when we talk about scale and some of the challenges around scale. But thank you, Mike.
Thanks again. Thanks, Richard. I just want to go back, if I can, to Hamish, just to ask. You mentioned in your elegant description about responsibility systems and including more of a performance element in it. Could you just expand on what you mean by that performance element before I go into the last question of this session?
Yeah. Thank you, Michael. I will endeavour to do that. When you look at healthcare systems at the moment, and it will differ depending on where you're placing kind of the focus. But what we have is an abundance of kind of arbitrary activity measures, and they will be different in different parts. So what will be driving Clare in primary care, whether it's sequins, whether it's QoF, whether it's other reporting mechanisms actually that impose and get in the way often of doing the work that needs to be done, will be different to what matters to people working in social care. And obviously in the acutes, it's the statutory performance metrics and the obsession around whether it's 92% bed occupancy rates or the average switch of A&E metrics. None of them are based around what we need to do for a human being to help them live a better life or to give them dignity in death. So we need to understand who our patients are, who are causing us the most amount of high consumption across the system and within the component parts, understand then what their needs are, and then derive outcome metrics based on an understanding of that. That, for me, creates what you call purpose-based measures. What you shouldn't be doing, and what we are tending to do too much and consistently, and we're seeing it even in elective care, is trying to obsess about getting activity measures up or down without understanding who are the people behind those activities that are causing the performance problems. So there needs to be a shift, and it's not necessarily throwing the baby out with the bathwater. So for me, episodic length of stay is what it is. It tells you in the moment how long a person is staying in a hospital bed or in a hospital environment. But what we should be complementing these arbitrary episodic measures with is more holistic measures, so cumulative length of stay over a year or two, for example, because that will give us a better indication of the effectiveness of the service system to better meet the needs of someone who we need to care for. It needs to be purpose-based. So what matters to you? How well are we doing that? If you are effective in anything you do in life, you will be efficient. But we tend to be thinking about the problem from an efficiency perspective. And it was Peter Drucker's classic line is, you can be incredibly efficient being inefficient. And we need to think of that again over time. So are we doing the right type of work for you over a week, month, quarter, year, multiple years? We need to shift the dial to move performance management away from an obsession on activity, and moreover, also a corresponding obsession on individual performance, when actually we should be thinking about more system metrics.
Thanks for the clarification. I think there's a PhD in this for you somewhere. And Neil, you wanted to come in around the population health aspects. It now comes in. I'll come to the final question, which I'll ask you all in a second.
Sure. Just very briefly, Claire's done it before, so but however, we're focusing on across our primary care network 400 patients who don't have any long-term conditions labels for themselves, but they come to primary care general practice 20 times a year, so i.e. 8,000 consultations. They attend ED 5 times each on average, which is 200 episodes. And I guess what for me the journey is, it's not to kind of blame individuals. So individuals are reaching out to a door of entry into a system. I think what we want to do for this population is do a health check, but really a well-being check. So what are the wider determinants of health? What's their employment? What's their housing? What's their kind of situation? What's their family support? And then think through. And often when we're thinking things through, I guess what we're not thinking is, well, general practice can do more to solve these kind of things. But actually, if we have a data set, if we understand what the challenges are, we could turn to colleagues in the voluntary sector, in charities, and other organisations, and for very little of the health pound or the health system pound, we can make quite a big difference. So I guess that's the frontier that many of us are currently exploring.
And I'm going to direct the question at you initially, Neil, because it's just flowing on from that. We're obviously looking for outcomes that everyone in the ICS can share, and those measures will be very helpful to look at the performance of the ICS. So how are they going to be judged? Taking the fact that many of the things you've talked about have quite a lag time before we really see an effect of that integration. But are there any other measures we could be looking at and outcomes that we could judge the success under an ICS on?
I think the real success would be, I guess the journey from a commissioner-provider relationship to a system that meets people's needs. So in what way do we actually, building on what Hamish said, how do we start understanding that really the health system is not about money and budgets and targets, it's about making sure that we meet individuals' needs. And how do we scale that kind of data collection to make sure that actually that's kind of almost the top barometer of the system? So I think if I was to set some KPIs, the first one would be understanding what people need from their health and care system, and then measure that and track that 6 monthly.
Thank you. Claire, you must have thought about the outcomes. We're over-measured. We're not under-measured, we're over-regulated, not under-regulated, but are there practical areas that you would consider that we should be looking at so that the public gets to know what's happening and that there is progress being made?
Yeah, there are. But I'm going to focus on integrated care because clearly you can have to, and I think what Hamish said, I echo. Okay, again, it's difficult to set an outcome for integrated care. It really is difficult. You can set some outcomes around continuity, but they tend to be based either continuity in primary care or continuity in secondary care. And as a start of 10, I put as a facetious comment that one outcome is 0% referral letters. Because as I said at the start, a referral letter is a failure of communication, all right? Because it means you're not using a shared electronic record, you haven't got data systems or electronic systems that can move patients into the right place. Often patients are in the wrong queue. Now, having thought about what I would want if I was to wave a magic wand, I think I'd actually look at it the other way around. And one of the problems that our patients face is this constant revolving door. So you might be discharged having had a surgical procedure. That surgical procedure may go wrong. You might have an infected wound, which is very, very common. We may want that patient seen by the team that has seen them in the hospital, but actually now we have to write a letter or we have to send them through casualty in order for them to be seen. You might have a new diagnosis of rheumatoid arthritis, all sorts of things. You might have a new diagnosis of motor neuron disease or cancer. And I think we need to be creating continuity across the systems. And I've thought of what I call a week, a month, a year, forever. So after a minor procedure or a diagnostic workup in a hospital, you should be able to provide continuity across the primary secondary care interface for a week. How that's done, I don't know, but you can sort out telephone helplines or whatever. A month for a much more serious diagnosis, a year for something that is a chronic disease, and forever for some catastrophic illness. So the patient, through whatever means, can actually self-refer back into the system, and it may be that we then develop multidisciplinary teams for the more complex issues. But rather than having, as I said right at the start, a system, which I think we're the only healthcare system in the modern world that is predicated on outpatients community. We need to break down that wall if we're going to, and then we can set the outcomes. So if we set a really harsh outcome, no referral letters, now I'm not saying that that's possible, but if you start to be brave and actually to start, and I think as Hamish said, to start where the patient is and stop these revolving doors, stop me as a GP having to spend hours on the phone to get somebody seen who's just been discharged or to follow them up, and actually work as a single health system, which is what I hope ICSs will be. And use digital. Nobody's really mentioned, other than myself, the digital revolution we're going through. And digital will help all of this. Digital will help put those 30% of patients who are in the wrong queue into the right queue. So those are some of there's no simple solution to outcomes, because people much cleverer than me have thought of what we need to do.
Well, I think you're not alone, because in the chat we have people mentioning it as well. And Phil Wavell has come up with the projects they're doing over in Humber around digitally enhanced healthcare. From my own point of view, I did a lot of work in the first 6 months of COVID, looking at the experience in one large trust and the CCGs around it about the adoption of digital technologies in normal practice. And it's interesting that that step change has been, to some extent, has persevered throughout, but I rather see a pullback now away from that. And maybe Claire,
can I respond to that? And I have got a conflict of interest, but we saw 1,000% increase, 1,000% increase in digital consultations over the pandemic, and that, I mean electronic communications. I don't mean telephone, synchronous telephone or video. I mean asynchronous. We then saw a pullback, rather like the monks in the Middle Ages with the printing press, that somehow this must be bad, till of course the paper came out that showed patients really quite liked being able to communicate. We need to, of course, sort it out. We're in the very early stages of learning how to use digital consultations and digital systems. But actually, the future is there. The future is digital systems supported by AI, patient empowerment, putting people into the right queue, and not just for chronic complex conditions. This is the right queue for any condition with choice, which you can have. But actually, so, Mavis with her serious chronic illnesses can have her face-to-face and much longer, and Kevin with his acne, who only needs a sort of, brief consultation, can be in the right queue. And I think we've got to be really careful that we don't create a sort of anti-digital, as I said, like the monks created an anti-printing press.
Totally agree. Stephanie, I'm just going to come back to you if I can, just for a last word, in terms of your observations around how, I suppose, some of these innovations that are helping ICSs, and as to whether that is making progress in your view, or are we getting a little bit stuck and perhaps going back to the mean of the previous ways of working?
So I saw a huge shift during COVID. Previously, innovation used to look like, I suppose, ours. It's now, it's old hat now. It was putting expanding clinical roles, putting a nurse in a traditional doctor role was innovation 5-6 years ago. It's now very much digital focused, moving more into AI. I think the thing that I don't see changing is that breakdown of barriers. So they're very much still positioned as a secondary care solution or a primary care solution. And actually I was in a workshop with an NHS team, and we were looking at a digital solution, and nobody in the room, apart from one, knew what an ICB was. So I think that was quite telling. So yes, I see the innovation shifting in terms of becoming a lot more sophisticated, but actually in terms of how that sits, I haven't seen any changes in there.
Well, thank you very much. We've come to the end of a very rapid hour, and thank you for all of contributors this morning. I'm going to now hand over to James for the second section of this inquiry. Again, thanks to everyone, and keep putting in the chat. It's really useful as a chair to be able to see where this debate is going and hopefully enhancing it. Thank you.
Thanks, Mike. And thank you to Claire, to Neil, Stephanie and Hamish for your contributions this morning. We're moving on to the second half of this inquiry session. And I am delighted to welcome to that 4 fantastic speakers who have joined us. We have John Rouse, City Director of Stoke-on-Trent Council, Des Breen, National Clinical Advisor for System Transformation at NHSE, Claire Fuller, Chief Executive Officer at Surrey Heartlands and Care Partnership, and Richard Murray, Chief Executive of the King's Fund. And so I'm going to ask each of you, first of all, to do your 2-minute introduction to contribute to the session. We've heard a lot about how the integration agenda should work in practice. We're stepping back to a slightly different perspective here, which is looking at kind of system level and what are the conditions required for integration to work at ICS level. And that's what the questions will be exploring, as well as exploring some of the issues we've already got into around the adoption of innovation, digital technology and so on, of which there is already a very lively conversation going on in the chat, which feel free to refer to as I will too through the questioning. So if I can go to John first, then Des, then Claire, then Richard, and then we'll open it up to questions. So John, warm welcome, good to see you.
Morning everybody, and thank you for the opportunity to join you this morning and just share my views and have the opportunity to listen to other people's perspectives as well. When you get asked to do a panel like this, it's a wonderful opportunity for some self-reflection. And my first reflection in preparing was that it's now 14 years really that I've been directly involved in the integration agenda. It started in 2008 by being one of the pioneers for Total Place, which you may remember under Gordon Brown's administration, which was all about how do you join up public services within places to secure greater outcomes. From there, then spent 3 years at the Department of Health and Social Care, introduced the Better Care Fund, took the Care Act through, integration pioneers, if you remember those, and then on to Greater Manchester to see whether I could actually make it happen in practice. And you know, I look back on that with a degree of pride and also a degree of frustration. Pride that we actually did shift outcomes, we increased life expectancy, we reduced morbidity. I think I know why we did that and how we did it. Frustration because it always felt that we were pushing against and having to push back against the sort of established orthodoxies and hierarchies that persisted and ultimately meant that Devo mutated into something quite different. But nevertheless, I think there are lessons to derive from that period, which we'll no doubt get into in the conversation. And now as City Director for Stoke-on-Trent City Council, in an area, Staffordshire and Stoke-on-Trent, obviously still carrying the legacy of mid-staffs and everything that flowed from that. But actually a very dynamic system as well, with a lot of ambition and confidence in terms of making sense of place-based integrated care. So that's what I bring to the table. In terms of just in my final sort of 30 seconds, the main themes I hope we'll explore this morning. The first is how do you create the right type of environment space for innovation to flourish within integrated systems. And I think there are some key lessons, particularly from Greater Manchester in that. The second is what do you measure and why? Because I think what you measure really matters in terms of how resources get allocated and where priorities really get set and get pursued. So that will be a second theme I hope that comes out. And the third is, how do you create a permissive environment that means the structures are secondary to pathways and the pursuit of outcomes? And hopefully we'll get into that detail as well. So I hope that's okay as a start for 10 and an introduction.
Brilliant, John. Thank you so much. And I think you've posed some really important questions there around innovation measurement. And I think more than anything, that permissive culture, so that a devolution actually does lead to variety in the best possible sense of operating model, which is going to lead to better outcomes. So we will be exploring all of that. If I can come to you now, Des.
Yes, thanks, James and Michael. Hello, everybody. My name's Des. I'm the National Clinical Advisor for System Transformation for NHS England. Until a couple of weeks ago, I was also Medical Director of the South Yorkshire and Bachelor Integrated Care System, and before that, the New Care Model. So I've been working at a system level for about 8.5 years as Medical Director. I'm currently an independent healthcare consultant also. So I'm just going to do a few reflections, really, because my glass is always half full with this. And going back to Clare's analogy with the plague, I think this is the best opportunity since the NHS at least was created to actually really address the difficult, wicked problems of health inequalities, population health, and personalised care. And I was at a meeting a few weeks ago with the NHSN and lots of universities, and this space was obviously very complex, whereby very many institutions were putting their hand up and saying we're going to concentrate on population health and inequalities, but nobody actually knew that those were actually doing that. So I think one of the opportunities is to truly embed life sciences into the integrated care and innovation hubs around the place, so that really we can explore the landscape. And I'll just give you a few examples of how I think that can work. So I think also this gives us a great opportunity for the life sciences and the ICBs to actually get the right data to inform the population health. Often we actually collect data and wonder what to do with it, but actually what we do is ask the question and then get the data to fit the question. So as an example, when our system is looking at our cancer data, we know we're behind, but actually if you risk stratify it with demographics and then compare neighbourhoods with their historical 2-week wait referral, we got 150% difference in the cancer presentations between neighbourhoods, and therefore you can begin to see therefore that sort of data at system level. We know that 10% of our neighbourhoods represent 80% of our problem, so therefore you can put screening programmes and health checks and behavioural nudge interventions in there. And this is one of the opportunities for integrated care and embedding life sciences. The second point I want to make is the right intervention. Core randomised controlled trials are really good. We need immunotherapy, we need the blood tests for the diagnosed and 50 cancers, but actually what we need is more QI methodologies to be able to actually get what we know and implement in practice. So to give you an example of population health and long-term conditions, we know that blood pressure is bad for us, but why do the vast majority of the people don't present? And why, when they do present, that we don't actually probably treat them 100% correct all the time in the way. And using that sort of data to be able to predict where these people are may actually give you targeted interventions to be able to do that. I think the other thing to say is this gives embedding life sciences into ICS we can all ask the problem and then get the tech, rather than the tech and then look for the problem. And I think, there's fantastic technology and digital out there, but sometimes there's not so much stuff and it's looking for a role. And you look at the long-term conditions, there's lots of, a lot of people have multiple long-term conditions, but there's tech for individual things, and how do we actually better coordinate that? And the other thing I want to bring in here is the personalised care with that, because while listening to some of the comments earlier on, we want to roll things out. Actually, we've got to personalise it as well. So the Living With and Beyond Cancer programme, some of them have been unbelievably successful, and a lot of the patient needs are not medical; they are actually to do with debt, sex, job, and so on and so forth. And the same with the cardiac rehabilitation programme. If we personalise that, we need to be working with our local authority colleagues and the voluntary sectors to be able to personalise care. Park runs and the sort of health centres and so on and so forth, and the sports centres and so on and so forth. Connectivity has been mentioned, and I think that's really important. Just to go back to your primary care example, we've got an opportunity to strategically commission this. because, you know, while shared care record has been mentioned, primary care dentistry and optometry have got no access to that sort of thing, and that's going to be a cornerstone of primary care and prevention going forward. We mustn't see ICBs as a big CCG, which providers and commissioners and regulators working together. But what we have got is an opportunity to strategically commission across a system. And there is a tension between system and place, just going on from Michael's earlier points. So you look at the 10 high impact interventions. We've got good interventions to prevent pharmacy errors when they go from primary into secondary care, but only 50% of our places have implemented it. And so we've got an opportunity to decrease variation in that way. And the final point I want to make, only because nobody else has mentioned it, is the innovation and the technology for the staff. We've talked a lot about how do we move staff and how do we use there, but you know, there's a lot of innovation there which will improve safety. The nuclear industry and the rail and the aviation industry actually use technology to decrease some of the human error, but also we can use innovation in life for the aids for that. So as an example, artificial intelligence, we've got a system now that can read mammograms, and if we can do that and make sure it works and roll it out, will be a massive boost to the workforce, being able to be redeployed and so on and so forth. And also there's other things that people have mentioned in the chat. You can schedule outpatient appointments through the night using some of these systems. And I think the other thing about the innovation is some of these innovations can actually be are so good that can be done by staff with a less broad range of competencies, so capture endoscopy, some of the robotics, and so on and so forth. So I think we've got a great platform to be able to embed the life sciences within an ICS. I mean, somebody said, who else should be on the pitch, not the subspecs? Well, life sciences should be embedded within the ICS in innovation hubs for some of the reasons I've said. And I'll stop there. Thanks, James.
Thanks, Des. Thanks, Des. You raised some very important points there in something actually building what John said, which is about true integration. It's not just between health and social care, but it's with all other services, particularly if we want to build a preventative health system or well-being system, as I think Hamish described it earlier. You talked about data both as providing a single patient view as well as providing the basis for population health management. So it's a good opportunity to plug the previous session we did on health data, which can be found on the Commission's website. Do have a look at that, but I agree with the importance of that. And I think particularly we were definitely going to pick this up, having a more solution-based approach to tech, rather than just promoting a problem surfacing based approach to tech. So rather than just plugging solutions to problems people think they don't have, actually bringing those problems out in the first place is actually the best first step to innovating. So thank you so much. Claire, I'm delighted to have you with us this morning. Over to you for your introduction, and then we'll come back to Richard and then to questioning.
Thanks so much, James. Good morning, everybody. I'm Claire Fuller. I'm a GP. I've been a GP for nearly 30 years, and I am the Chief Executive of Surrey Heartlands, and I've been the leader of the Surrey Heartlands system for nearly 5 years now, with through various guises of STPs and ICSs and ICBs. And then in November, Amanda Pritchard asked me to undertake a stock take looking at integrating primary care, what is working well, why it's working well, and how we can replicate it. And at the end of May, I published a report, a fairly short report that was made up of a vision for a future model, which was peppered with case studies, really detailing where the vision had come from, to show that actually it is happening, the integration is happening already all around the country. And we came up with a very short list of recommendations. And the report was accompanied by a letter signed by all 42 ICS chief execs committing to implementing the recommendations of the stock take, but also with some asks of NHS England, HEE and DHSC for the things that we needed help with to enable us all to succeed. So the outcome really the stock take talks about people talking in teams rather than talking in siloed organisations. And it is teams wrapped around practices to better improve access and continuity. And we talk about these teams at neighbourhood and at place. And the teams are there to better deliver integrated urgent care, to better deliver case management of our most complex and vulnerable patients. And this, again, we've heard a lot about today already. It's the anticipatory care, the personalised care agenda. And then also how we work with our communities on prevention and on addressing health inequalities. And we describe that in 4 areas, so what people can access from their home, in their neighbourhoods, in their place, and at a system level. And then we spent quite a lot of time describing the environments for success, and there is a lot of work we need to do as systems on estates, so not just about NHS estates, but making that change to involve to move to one public estate, but also making better use of our commercial and high street estate. We talk about data and digital, and I'm very grateful for Neil for his leadership on this work stream, but it really was very much about the importance of population health management, the data sharing, the move to one single record that can be accessed by people and what the blocks are in place. And there are some national asks around that. And then the third piece was really around workforce and leadership. And Gordon Messenger's report came out at a similar time to the Stocktake, which was Gordon didn't really go that close to the primary care leadership space, and I think there's a number of quite simple things that systems can put in place. And at the same time, we also commissioned a brilliant report from the King's Fund, and I'm not just saying that because Richard's following me, because I regularly say this, that looked at how you drive the levers for change in primary care. And what it showed was that in England, we have relied more heavily upon centralised financial incentives than anywhere in the world, and that actually there's very little evidence that it drives outcomes. And the best way for people to succeed is to give teams clear remits and then work in a high trust environment. So the report was published in May. The further away I've got from it, I increasingly realise, although I was asked to look at primary care, the report isn't about general practice, it isn't even about primary care. And interestingly, we did spend quite a lot of time looking at pharmacy, dentistry and optometry, but actually I came to the conclusion that audiology should be included within that family of primary care. It doesn't really make sense why it isn't. But the report isn't about primary care, it's actually about systems and about how systems should organise themselves to deliver health and care to populations in a way that works for people where they live.
Fantastic. Thank you, Claire. That amazing 3-minute summary of what is an excellent piece of work, which I'm sure everybody has looked at, and we'll explore it a bit more in a moment. Richard, if I can come to you.
Great, thanks. So Richard Murray, Chief Executive here at the King's Fund. People will probably know we've worked for a long time on the integration agenda. And I think I've probably been around this for even longer than John has, both in the Department of Health and briefly in NHS England. I'll try not to repeat things people have said. Just a few points then. First off, this is not a finished article yet. The Act of Parliament was very deliberately permissive, as we speak with a lot of systems and indeed a lot of providers too. A lot of those leaders are still thinking through, well, how does this work? I've been at 1 or 2 board sessions where you look around the room and think, ooh, there's a lot of people around the table, aren't they? And so you had a very inclusive approach to the board. Now you think, is this really a board with this many people around it? So this is still a system in design. And I think in many ways, then, this is a great timing for what you're doing, James and Mike, to think about how we make sure life sciences are built into it. But we do need to recognise that it's still a work in progress, very much a work in progress. Just to say as well, we did a session here recently with people working particularly in emergency care, just to reflect for how many stuff, just how tough it is out there at the moment. And so as you're framing this conversation and framing this debate, it really has to talk into that agenda, or I fear it just hits the wrong note, both with staff and indeed I think with patients too. I don't think we've ever been in a place quite where we are now, and the Health Select Committee said that very articulately on the workforce issues yesterday. And then just a little bit on integration. So quite a lot of conversations both with the centre and others about if we got the right outcomes, we'll drive behaviour. If only we could get the right financial incentives, we could drive behaviour. And I think this does put the cart before the horse. What you want to do is know what it is you want to do. And once you've worked that out, you then try and find an outcome that matches it, or an indicator that matches it, and you find the easiest and most simple way to make sure the money's in the right place. If people's hearts and minds are not there, there's no amount, I think, of clever definition of outcomes or really complicated financial incentives that will make people do something. that they don't really believe they should be doing. And although that sounds like a huge ask, I think we saw through COVID that it could be done. And I think we can see both across large parts of the NHS, local government, the voluntary sector, and I think life sciences too, that bit is probably in place, that there is both perhaps too much of a burning agenda sometimes, common platform, that we could work through. And I suppose this is partly a plea about trying to avoid over-engineering something and rely, as Claire said, at least at the start, on a high trust environment. And many of the things that work for engagement and work in that process will work for as well for life sciences, working with the NHS, as they do for the voluntary sector, working with local government and working with the NHS about building those relationships and understanding where people are coming from. And we see quite a lot of really fantastic innovation coming out of life sciences. Companies, sectors then puzzled why it's not being taken up. And I look at the evidence that they've presented, and do you know what? The King's Fund would never issue a report or advice on that grounds, because it's really, really long and really, really complicated. And there is something here about trying to understand the perspectives of the different players involved here to try and make sure we get those key messages across. Because I tell you, I don't know, Claire, John, 30-page business cases from individual companies just go down like a lead balloon. There's something here about how we build those relationships and really do build in life sciences alongside the voluntary sector and alongside local government and the NHS. Thank you.
Thanks, Richard. You remind us there that integration needs to contribute to alleviating the current crisis, or else it's going to be a bit of a sideshow. And I think that's a really important reminder. I think something about what you and Claire have said brings me back to this idea around, or ideas around, kind of new public management theory, and which I think are not very useful anymore for the kind of vision that we've got and that Claire has articulated around a high trust environment. This is going to be about letting go, not being untransparent, because actually it's going to be around being more transparent about performance data, but not fixating on one particular outcome over another, and particularly as populations do vary across the country, across those 42 places, allowing for some flexibility there, actually, so they respond to genuine population need. And then you made the point about innovation, which we're going to return to. So I'm going to ask the first question on our first topic in this session to Claire and then to John. I think we're all agreed, more or less, that the creation of ICSs was a necessary step to devolve power and decision making closer to patients and clinicians. And ultimately, what we're trying to do is make this agenda work, I think, rather than create yet another alternative ideology that we focus on. So to Claire and John, what I would like to ask you is, what autonomy, or how much power do ICSs need to have in order to do what is required of them to both deliver the integration agenda with everything that we've described, also, of course, to alleviate the crisis that we're in, and to achieve true integration? So I come at this with a prior, which is I'm very sceptical about the centralisation of public services as in general, so I will get that out there. But I'm really keen to understand from you what that kind of devolution and authority and accountability at ICS level would need to look like to deliver on this agenda. So if I can come to you first, Claire.
Thanks, James. I think it's really interesting in terms of different use of words by different bits of sector in terms of autonomy and power, which are sort of really strong words. So as the ICS chief exec, I am very clear that I am accountable for the financial sustainability, the delivery of my system, and that is broader than the NHS bit. However, there is a statutory responsibility that I need to meet as part of the NHS, flowing up through region and into the centre, and I'm very conscious of the need to meet my financial requirements and the constitutional standards. So having said that, the bit that is really important about ICS is the fact that we have the Integrated Care Board and we have the Integrated Care Partnership Board. And for us in Surrey, I have two different chairs. So I have Tim Oliver, who's the leader of our council, chairs our Integrated Care Partnership Board. And I think that's really important because that gives us the democratic accountability as well as the statutory accountability. And I think if we focus too much just on the integrated care board agenda, I think we will lose the potential of ICSs, which is really to start to work in true partnership and also to address the wider determinants. So, you know, it's the classic chestnut, isn't it, that the NHS on its own can only improve health outcomes by 20%. And unless we work across the full partnership, we're not going to maximise the outcomes for our population. So that's why for me, I am very clear that I've got 2 chairs and 2 boards, and both are equally important. But I'd be interested to hear John's views as well.
Thanks, Claire. John?
Thanks. If I could sort of focus on 2 areas. One is governance and the other is resources. They're not exhaustive, but just for time's sake, if I concentrate on those 2. So in governance terms, my experience of accountability up through NHS England when I was in Greater Manchester running the Devo system was that we had too many conversations that were just about the wrong things. So I'll give you an example. At every one of the accountability meetings, which were broadly quarterly, I would be asked in huge detail about the cancer waiting times, and you know, we would go into all the different aspects of that. I was never once in my time there, which was almost 4 years, I was never once asked about cancer outcomes ever. How many people had lived or died, quality of care, quality of aftercare, never came up on the agenda ever. And that was a broad trend, really. So I would insist that at the beginning of the meeting, we gave an overview of the work we'd done over the previous quarter, and I would want to focus on things like our reducing smoking programme, our work on alcohol and drugs, our work on homelessness, and there was really no interest from NHS England improvement at all. They just couldn't wait to get onto the bit of the agenda, which was about UEC, about planned care waits, etc. And it's not that those things aren't important, of course they are, but there is a narrow obsessiveness about a relatively small number of process measures that obscure in terms of the accountability framework, the bigger ambition and vision that all integrated care systems are seeking to pursue. Which brings me back really to my previous point about the importance of knowing what you're measuring and why you're measuring it and what are you obsessing about, and trying to align the national interest and the ICS interest. Which then brings me on to resources. One of the wonderful things about the GM experience is that the brilliant Howard Bernstein went in advance of me and negotiated a roll-up of all the transformation resource over 4 years at national level and had it transferred to the GM system. And although I'm sure we didn't get that perfectly right in terms of the allocation of that resource, I'm pretty sure that we made much better decisions and much more efficient decisions around the allocation of that resource than how it actually got spent nationally. Actually, some of it didn't get spent nationally because it was effectively clawed back by the Treasury in terms of insisting that it offset overspends elsewhere in the system. And in terms of that allocation of the 450 million we received over the 4 years, we learned a huge amount. The first was that it is the combination of access to resources with the right leadership that makes the difference. So we allocated a proportion of that 450 million to every one of the 10 place geographies in GM, and what they achieved with it was completely different. You know, so for example, Stockport at that time, with the power of hindsight, were not ready to receive those resources. They were at 6s and 7s. They spent all their time arguing with one another across NHS local government. And frankly, we would have been better off waiting and not allocating the resource to them and conditioning it on getting the right relationships in place first. Whereas, for example, at the opposite end of the spectrum, a Tameside, a Salford, a Bolton, you know, really spent that resource well and made major step changes in terms of the quality of care and thus the outcomes they were able to achieve. I think you might be on mute, James.
Sorry, someone has to do it. You've both made really important points, and I want to, well, we're going to come to the finance issue in a moment, so I'm going to ask Richard to follow up on that, but I just want to come back to this point about sort of targets or data and performance. So to put a sort of provocative question, do you think that ICBs, I suppose, or ICBs and ICPs as currently constituted, have the authority or the confidence to reject national targets in favour of a set of local targets that better reflect the needs of the population, are better focused on outcomes rather than processes? And if not, what would be required to make that happen? Claire?
Yeah, so I would say no, we are still very much monitored on our constitutional requirements. I would say if we were meeting them uniformly, then we would have greater freedoms. However, as an ICS, we will be looking at what is locally important to our populations. And the things that we're locally looking at are improvement in patient experience of access, generally, looking at improvement in continuity, but also looking at improvement in health inequalities across neighbourhood. Those will be my local, our ICS strategy is very much built around the stock take vision, which then drives a lot of the rest that we're doing, which will be, and those outcomes we will monitor through our Integrated Care Partnership Board rather than through our Integrated Care Board, which we will leave for our more traditional constitutional targets, NHS targets.
Got you. Thank you. Helpful. John?
So no, I agree with Claire. There isn't that freedom, and ICSs don't feel that freedom. They won't get away with it, even if they tried to reject those national imperatives. My personal view is that we need to come to some sort of settlement on this in terms of a minimum number of national indicators that all ICS abide by, but then an ability for each ICS to combine those with local indicators that make sense locally in terms of the particular ICS. The key then is that in the accountability relationship, the national body in NHS England take as much interest in the local indicators as they do the national indicators, so that we have a balanced shared conversation that deals with what's important to them, but also what is important locally.
Yep, very good. Thank you so much. Richard, going to hand over to you. There's been lots of chat about finance issues, so your question is going to be very helpful, I think.
Yeah, thank you, James. And hi, everyone, again. For those of you who joined for the second half of the session only, I'm Richard Stokes, Chief Executive of the Yorkshire and Humber Academic Health Science Network. So as James pointed out, John's dipped into this question already in terms of finances and delegation, and John just talked very eloquently about how in Greater Manchester, the relative maturity of different places to be able to handle devolved budgets. Des and Richard, I'm going to, in effect, ask for your views of the same issue. But, you know, just to put it more formally, how should integrated care boards, ICBs, delegate their finances to prevent competition for resources, particularly between place and provider collaboratives? So I don't know, Des, if you want to start that conversation. You've obviously had experience as both a commissioner and a provider side across the system. How do we delegate those finances in a way that encourages collaboration and prevents competition?
Yeah, and thanks so much. And it really does follow on from what John and Claire was saying, because, you know, it needs a very strong ICB to not get drawn into the usual suspects of elective recovery, 2-week waits, system control total, and so on and so forth, and ignoring the things that ICBs and ICPs are actually set up to do. That's population health inequalities. So I think really this for me is more of a behavioural change in that. And I completely agree with John's point. Actually, each place is in a very different place. So this is not a panacea of how you're going to get it done. I think it's a progress and work in time. And I suspect that most systems, having looked at most systems, will actually let the money through fairly quickly to place and neighbourhood at the start. But as they develop, because there has been a bit of a rush for July the 1st, if I'm honest, as they develop, we'll then start to look at some of their priorities in terms of their population health and health inequalities, and some of their strategic commissioning that they'll be able to do. Because the legislation has been quite helpful, but it doesn't give total autonomy or power to ICBs or ICPs. It helps. We still have independent organisations within that. So I think going on to some of the outcomes, it's about a shared purpose, it's a cultural change, it's the behavioural change, it's getting the things that we want to achieve, and actually getting the members of that ICB and ICP to actually commit and to do it. And so going on to some of the things that you'd want to see about that, I agree with everybody. It's not just the hard targets. It's also about the processes, like John said, like smoking and so on and so forth. But also it's this personalised care and turning the agenda to from what's the matter with you to what matters to you as a population, and so on and so forth. And if we can get to that, then I think we can start to strategically commission and let the money flow based on the problem we're trying to solve, not the target we're trying to hit. Because if you, and I agree with the comments that are maybe low about the permissiveness and the trust. If you set the targets, you often hit the target and miss the point. So I think it's crucial how we do that. And there's nobody, I don't think, has actually got this licked as a system yet. And I think this is work in progress. But if we focus on the right things to do for the patient and the population, and then the behaviours that will wrap around that, then the money should actually flow to the right place.
Thanks, Des. And Richard, same question to you. I mean, in your introduction, you talked about the fantastic work that King's Fund's done on integration. How do we get the money flowing in a way that absolutely incentivises collaboration?
Well, I think there's a couple of things, I'll reveal my hand. I led on resource allocation in the department for a decade, so you've kind of picked on a bit of a hobby horse. So I think for ICBs and their relationship to NHS England to maximise the financial control and freedom that ICBs have, particularly on the capital side, but not only on the capital side, there's a tendency to believe in a kind of mirage of control, that you create a little central budget, it's a separate budget, make everybody apply for it, that this gets you what you want. It doesn't work. And I think, John, some examples you give, it's a mugs game. But equally, then I think for ICBs not to replicate that approach, which is, can I create lots of separate budgets and make everybody apply for them? You can do it in a number of very specific areas, but try and keep the financial system straightforward. There's an enormous power in the analytical resource that NHS England and the department have put into allocations over the years. They're all based on individual patients registered with the GPs. So ICBs could cut the budgets in any number of different ways, as long as they could get the analytical support to do so, which is important because you need to show equity. So if you're an ICB splitting up money across your patch, what you don't want to do is come into conflict at place level with people pointing over the boundary going, hang on a minute, look what they've got and look what we've got. So try and use the knowledge that's already there and to maximise transparency about how those budgets were set. Then I think in some geographies, it's relatively straightforward. They have very well-established places. Often they were CCGs before them until quite recently. You've got a structure there to build on, and often those are matched by the local government footprint. And I think that answers the question. Unfortunately, there are many other geographies where people can have to work that out, and that's that process of learning. That conflict between place and provider collaboratives, I'd slightly reframe that. I mean, the money is all going to end up in providers' bank balances. If you like, in the old commissioners speak, commissioners ultimately either pay it to NHS providers or to voluntary sector providers or to private sector providers. So in one sense, we know where the money's going to end up. Of course, it all goes through providers. I think I'd rephrase it slightly, that there is a challenge that some NHS providers, some provider collaboratives have a stronger voice on the ICB than arguably does general practice, than arguably does the voluntary sector, than arguably does the private sector more generally. And that's where the challenge might come. How do you make sure that those early stage conversations, you don't think, do you know what, wouldn't it be better we just handed over all the money to the provider collaborative, rather than allowing it go down to place level and allowing them possibly to hand it over to the provider collaborative and to work with them together. And I think there's that imbalance of power potentially that we can see in the structures of ICBs. And that's where you need to make sure that those other voices, local government, the voluntary sector, primary care, are really built in so that you can make sure the money goes to the most appropriate place. Because of course, it isn't all going to go to place and it isn't all going to stay at ICB in most geographies, but trying to make sure that there's that little bit of grit in the system so that those other voices are can be heard and we don't end up slightly replicating the old world. I'll stop there.
Thank you, Richard. Really fascinating. I'm just going to ask you actually just for a little bit more on that point about how do we redress that balance, therefore, the voices around the table. I think there's often a problem, I think particularly the voluntary sector, to demonstrate evidence-based impact of some of their pathways. How do we make sure there's a level playing field when it comes to the allocation of resources around that table?
Well, I think there's a role here for, and again, I should be careful because it varies so much across the country how ICBs and ICPs have been set up, which is obviously a strength we don't want to lose. And there's a role here for the partnership. Is the board living up to what it is that we all signed up to? There'll be a strategy, there'll be a plan. How do you deliver it? If you think your plan was primarily about investing in primary care and the voluntary sector, and it turns out all the money's gone to where it was used to go, there's a fundamental challenge about have we done what we wanted to do, as I say, to follow the money, follow the resources, follow the staff. I think there's also making sure that without overburdening the board, that it has got a way of drawing on those other voices. And I say that because you can't have a board with everybody on it. This needs to be a functioning body with authority, but then there are different ways, and depending partly on both how big the ICB is and how it's structured, to make sure that those other voices are around the table. And if they're not around the table, then something's almost automatically wrong to start with about how these decisions been made, and have we ended up, to give an example of one geography, we seem to be spending an awful lot of time on specialised commissioning. Is that really where we thought that the health of the population would be improved? And I don't want to diss specialised commissioning, incredibly important, but I think, hang on a minute, 90% of the conversation is on hyper specialised services. Something's not right about how those voices are being heard.
Yeah, thank you, Richard.
Can I come back on that, Richard? Because I think Richard makes some really good points there, and I think it's absolutely right. And this is you know, how we get looking at most systems, most decisions and most transformation doesn't happen at the ICB level. Underneath an ICB is a myriad of place and transformational programs and so on and so forth, which is peppered by the right type of stakeholder. So while the ICB might want to set some strategic priorities, actually the change happens at ground level and so on and so forth. So I think there is opportunity within ICBs to actually be very, very inclusive, and then stick to the principles of which you're trying to set right at the start. Because I think I agree with Richard there. You know, if we're not careful, one of the risks is this becomes too NHS and too acute focused.
Yeah. But also, before I just hand over to James, just to draw attention to Claire's points in the chat, she's very wise about not falling into the trap of generalising what is a provider collaborative, you know, particularly in rural areas. So thank you for that, Claire. James.
Yeah, no, thank you. So we can just move on to a slightly different question now, or set of the topic, which is has been touched on by many of our speakers, both in the first half of the session and then in this half of the session, which is how we actually integrate the product, services, offerings from the life sciences sector in order to generate the kind of innovation that is going to be required to deliver better services. And I think even with imaginative ways of reframing the workforce, the reality is that the health and care system is going to have to become radically more efficient, and it's impossible to imagine that happening without better use of innovation and technology, because we're not just going to magic up tens of thousands more healthcare professionals in the next few years, even if they were affordable. So we're going to talk about how that innovation agenda can be properly integrated into the integrated care agenda. And I'm going to hand over to Keith, who's going to ask the first question on this from.
Okay, thanks very much, James. So I think if I direct this initially to John, and then perhaps Des might want to follow up. And I was conscious, John, of your comment about permissiveness. That's been sort of a theme throughout, I suggest. So that in mind, so and of course the Manchester experience, what needs to be done to ensure the life sciences sector becomes fully part of the integration programme to aid, if you like, the wider health ecosystem, whether that's R&D, the joy of reforming medicines management systems and other sort of technology type of control or approval systems where pilots fit. So on the sort of on the ICS type of side, but on the other side, how does the life science sector itself need to adopt or adapt, sorry, to improve its relationship with the health and care system. So both sides of the equation.
Thanks for that. And I'm very aware, Keith, that you helped us as well in terms of GM, in terms of getting some of this set up. So I just want to recognise that. So I'm very proud of this element of what we did in GM and the fact that it endures to this day and continues to grow and evolve and has international standing. And the key decision that we took was a recognition working with, particularly in the first place, the pharmaceutical industry, and then more on the tech side, that there needed to be a dedicated space that worked for the life sciences and tech sectors. And that wasn't going to be, first and foremost, around the board table of the ICB. And so we created Health Innovation Manchester with its own governance structure, with the right accountability mechanisms, but a space that was very entrepreneurial, very permissive, very exciting, and with relatively light touch gateway processes to enable innovation, first of all, to come into the R&D cycle, but then when it was proven, to be quickly adopted across the GM system. And that meant we had to get the governance right in terms of those decisions. And I just checked on their website last night, and they've now got something over 100 live projects. There are projects that are now closed because they've already completed and been adopted across the system. What I like about the GM model is the push and pull of it. So the system can present problems to the life sciences sector and tech sector, and then sort of Health Innovation Manchester becomes something of a crucible that enables those to be grappled with and resolved, and then those solutions come forward and get implemented. But also it creates an environment the other way around, where universities, life sciences companies, tech companies can bring potential solutions to the table, and there is an opportunity to think as to whether there's a fit with needs and problems within the GM system itself. So it's a two-way process. And of course, all of this is underpinned by the Greater Manchester Care Record, which not only is used in terms of day-to-day work of practitioners, but through big data is able to provide anonymised data sets that can then underpin the work of Health Innovation Manchester in terms of individual research projects. I think it's great. I'm not saying it's perfect, but I think it's great. And I would like to see, a similar model through all the innovation hubs across the country.
And that's helpful, John. And on the other side of it, do you think that, is there something which the life sciences sector itself needs to, do they need to change in order to make the most of this?
So I think at the margins there are things that could be changed. I think one is that the life science sector has got to become more comfortable about describing failure. So one of the things I like in the American system, for example, in terms of their equivalent work, is that there is an obligation in return for some of the research funding and endorsement that they actually have to publish their trial results, including failures. Because I think you can learn as much from failures as you can from successes, and we shouldn't hide those. The whole nature of innovation is that we're going to fail, and that's fine. And indeed, some of the Health Innovation Manchester projects failed, and I'm pleased to see that they are still on their website with the description of what happened and why they weren't adopted.
Okay, thanks, John. Des?
I won't repeat what John said, because I completely agree with everything he said. But I think it's crucial that the life sciences are embedded within ICBs, within an innovation hub for a lot of the reasons I said in my opening remarks about collecting the right data, the right intervention, the problem before the tech and the connectivity and so on and so forth. And that's crucial for a number of reasons. And you just take the data at the moment. If some ICBs may turn around and say we haven't got the capacity to do it, but when you actually look, they probably have, and it's how you turn that capacity around to ask the right data questions, both from a macro thing and both at a personal level. And actually, the life science has been embedded within an innovation hub within an ICB going across the system is one way of increasing that visibility, because one of the stumbling blocks of all this is you've often got to spend to save, and in a year and in a in a system whereby we are constrained by the financial year and the system control total at the end, that's really difficult. And I think there's an element here that that there could be better some risk reward in terms of the life sciences if they need to adopt. I think, you know, from the second point of your question, that the life science is to adopt. Yeah, I think there's a bit of this co-design I did mention in the opening address about the tech before the problem, and really be in there. And also, when we actually come to embed technology that's proven to work, we're taking things that have been from a controlled environment into an environment that's not controlled. So from the test bed or the randomized control trial or the research into the implementation, and therefore it's got to be context specific. And if we think about it's context specific and personalized, therefore it won't fit everybody. So I think the life sciences has to be more flexible in the fact that once you get a good idea, it might not actually be able to be rolled out to everybody and everywhere for that reason. I've mentioned before, and in fact, John's just mentioned it, don't roll out things that don't work. And I think this QI thing about implementation is really, really important. And I think really a strong ICB should have an integral relationship with the life science and their innovation hub to be able to truly look for innovations, because, you know, when we are looking at our recovery from cancers and when we're looking at things, we are putting in interventions in place now, like behavioural nudge interventions and other things that we've never known before. And a key part of that is to ask the population that works. So we know that in 10% of the population, we've got a problem with female urology not presenting. So we've got to actually target that in 10% of the population, some of these things, and what interventions are going to be there. And we don't, so often the life sciences and research centres come to us with a project and a question they want to answer, but we often say, well, that's not the question we want to ask. So therefore, this is a question we want to ask. So have we got something then to answer that? I'll stop there because I've gone about this for ages, and I know you've got a research thing later on.
Indeed. Thanks, Des. I'm conscious of time, James. Do you want to carry on?
Yeah. Yes, I'll thank you, Keith, and thank you both for those answers. There's an interesting tension here, isn't there? On the one hand, we're sort of critical of the NHS of not doing adoption at scale well, and on the other hand, we're talking about how decisions about adopting innovation could be devolved to 42 different places, which is the sort of thing that usually causes a sharp intake of breath among the life science and tech sectors, although perversely that might be the best hope for more rapid adoption. So that's something I think we can explore, and it's a perfect segue, I think, to Jill, who's grappled with these issues for many, many years. Jill, do you want to ask the next question?
Yeah, no, thanks very much. Yes, this is my specialist subject, I think, and it builds on the conversation we've just been having. So if we've got innovative technologies that we know are clinically and cost effective, so imagine NICE might have approved them. Drugs are sometimes adopted really quickly. Sometimes new things like inclisiran aren't. But medtech and digital are much more challenging. You know, we looked at the data, it can often take 10 years for a new effective bit of medical technology to be adopted. So the question is, if we want to achieve adoption at scale, what needs to happen at a local level around sharing practice, cultural change, data collection, or anything else, procurement? We know is a bit of a challenge for companies. So what do you think needs to be put in place? And John, I probably should have said I was going to direct this at you first, but Claire will have a view too, I'm sure, as will everyone else. So John, shared practices, cultural change and data collection and procurement.
Yeah, so maybe I could use just a couple of case studies actually from GM first to sort of bring the point home really. Two different innovation projects, one that I was actually introduced by Salford Royal, one that was introduced by Health Innovation Manchester itself. Starting with the Health Innovation Manchester one first. So they've got a really interesting ongoing programme actually around where people have got heart devices fitted, whether that's pacemaker or something similar. They've embedded now chip technology that they can do remote monitoring in terms of readings from the device, which basically with an algorithm behind it is predicting when there is, measuring when there is deterioration and predicting when there is going to be a traumatic event. Incredibly exciting piece of work. The second one is the the polypharmacy project, which Salford Royal initiated around older people who were on more than 10 medicines. And that was a safety-based program, incredibly successful in terms of reviewing those medicines and working out what combinations were having the most adverse impact, etc. We definitely got the benefit of both of those projects in GM. But what was lacking was a mechanism for actually taking that learning swiftly into a national point for consideration with respect to national adoption and rollout. And I think that gap persists to this day. And I'm not talking about NICE here, although NICE is very important in terms of sort of formal endorsement of a particular piece of tech or medicine. But what I'm really talking about is a clearinghouse that is much more rapid, that basically says, you know, this research looks really beneficial, powerful. Which are the next 5 areas that are going to adopt this in terms of scaling up? Because it doesn't have to be just big bang. And I don't think unless somebody can explain it to me, I don't think we've really got that mechanism at the current time with the level of agility which is required.
No, that's a really good suggestion, because it's great to get some practical ideas out of this. So if there was a clearinghouse, would NHS England run it? Who would do the data collection? Would it then eventually end up at NICE? Just a couple of quick questions, then let's move on to Claire.
So Des might be better answering
okay.
that one.
Yep.
Yeah, I think the AHSNs have got a real part to play here.
Yeah.
I'm not saying that just because Richard's on the call. It could be that is the clearinghouse, but I'll just give you 2 case examples of what's it. So there was a couple of years ago, there was 10 high impact interventions that were all passed. 2 of them were TCAM, that's the medicines discharged from secondary into community. It would eliminate drug errors, fantastic, but yet only 50% adopted it in our system. I would agree with James, that one should be rolled out. There was another one that came out at the same time, which was an episiotomy scissor to make it safe. That was stopped dead in the waters because it wasn't disposable, it was metal. So there is something about the reality between what is possible and what isn't. And those are 2 examples where one should be rolled out and therefore strategically commissioned by the ICBs, and one whereby there was real clinical concern. And then the third reason why things don't often is because it's often it's often expensive, and it's the 4th of the 3 priorities. And the one I've listed here, as you were talking, was scan for safety. You know, if we introduce scan for safety, we could massively increase safety in there, but it comes at a cost up front, which we can't do in year budget. And just a 4th point, your clearinghouse, I completely agree. But I agree with John's point. You know, you don't do it once and then roll it out big bang. You roll it out again, then 4, then 8, then 16, and see what it works. And again, it will be context specific.
Thank you for those points. I don't know how we're doing for time, James. Shall I bring someone else in? Do you want to bring anyone else in?
Claire, I think she'd like to come in, yeah.
So I think the reason why we do this badly is that we don't have a theory of change that is recognised nationally, and we don't have a change programme. And really what we talk about is change in clinical behaviour. And often with the interventions that we're talking about, we will target a sector rather than a pathway. So I think some of the examples of things that have worked really well, it's because it has stayed within a sector, but actually, you know, particularly sort of some pharma interventions, it will be targeted upon hospital clinicians and then fails when it comes out into the community, either because of different funding models, because of different distribution models. And we need to get better about describing to clinicians the impact and the benefit for patients, because that will drive change quicker than anything else that we can do, including mandating.
That's really helpful. The clinician role is key, and I used to say change is not made without inconvenience. It's somebody's quote, and it's much easier to stick with the status quo, so you've got to explain the benefits. Absolutely agree with you, Claire.
Thanks, Jill. And I just want to, as in the last minute, I just want to give Richard a chance to contribute, because Richard, you've made a point in the chat about the danger of almost replacing the ICB as a quasi-national body where everything happens, and where actually there's a lot more going on underneath that, as has been discussed. I want to particularly focus on one thing though, which is around sort of governance and accountability around innovation and R&D activity. do you think there are any levers in that realm? You've given your view on sort of financial incentives, but around sort of accountability and governance, about levels of innovation and R&D that could be useful, that not just shine light on activity, but actually raise the profile of sort of innovation R&D activity at the various levels in the NHS that would actually produce positive behaviour change.
Yes, I think certainly to help ICBs, ICPs understand how they're doing and where the opportunities might lie. And if I slow down a little bit, James, it's because what I don't want is that John or Claire sits opposite an NHS England regional director being told off about urgent emergency care, elective care pathways, and why are you fourth from bottom on your innovation?
Yeah.
This should be something people want to do. This should be something that sells itself to people that work in the system. And the point at which you have to start performance managing it makes me anxious. Something's standing in the way, and I'm just not sure at the moment, adding another thing that we're going to performance manage or watch ICBs on is really going to cut the mustard. And I think if some ICBs, they're really great, but they're facing some giant providers who are actually controlling a lot of the money and controlling a lot of the decisions. So the ICBs then can have to go over to its Shelford group members and say, oh, what seems to have gone wrong here? So I think there's something here about the transparency and understanding the opportunity that I think could be helpful and could be powerful to raise the sites, but I'm a bit wary about adding to the to-do list. And I just wanted to say as well, James, very quickly, we've said a lot about what the NHS needs to do and local government and the other partners. I think some of the understanding of the life sciences about what would make the NHS change its mind, but isn't always great. They need to get closer to their clients, the people they want to work with, and understand what's really driving their decisions. I think that would make life a lot easier too.
Agreed. Thank you. Well, thank you to 4 speakers in this session. I'm going to hand over to Mike to close things out.
Thanks, James, and thank you all for a very rich conversation. I think what I picked up from that was broadly, we're not too interested in multiple incentives to get into this space. We're in the space. Claire, I thought your point about the difference in outcomes for ICBs and ICPs was a very important one, and you can focus on the things that are important for your particular ICS area. I think the issues around how we develop in the future and link to life sciences and work better with AHSNs, and I take your point, Richard, in the chat there around responding to John's criticism of lack of agility is important. But I think the ICSs and their boards have the opportunity to become agile, to focus on the things that really matter for the populations. And Claire, just to emphasize the point you made around looking at pathways rather than sectors, I think is very important. I think, James, we've probably got more than enough for what we required from today, from all 8 of our contributors. And I'd like to thank you and them for your contributions today.